Good afternoon, everyone. COE STM Kolkata welcomes all the participants for today's RDLS session. Today's topic is first line ART in adults and adolescents, management of ARV toxicities. And the speaker is Dr. Dolanchampa Modak ma'am. Dr. Dolanchampa Modak ma'am is the assistant professor of the tropical medicine and the deputy program director of Center of Excellence in HIV Care at the School of Tropical Medicine, Kolkata. She is also a master trainer for NACO and a faculty of PG Diploma in HIV Medicine course for IGNO. She has several publications in national and international journals.
ওদেরকে বলে দিও
We
তো
welcome you, ma'am,
যে
for
ওটা
today's session
অ্যাসিস্ট
and request you to start the session.
Good afternoon. Shetal, should I start?
Yes, ma'am. Yes, ma'am. You can
Okay,
start,
okay,
ma'am. Thank you.
okay. Thank you, Sita. So today's topic is first line antiretrovirals in adult and adolescent, management of antiretroviral toxicities.
Oh, ma'am, click anywhere on the slide and then press the next button. Yeah.
Ma'am, you are on mute.
Ma'am, you're on mute.
তুমি যে next slide যখন যাবো in today's session we will discuss the antiretrovirals for adult and adolescent. Simultaneously, we will discuss the drug toxicities, special information regarding the dolutegravir toxicity and tenofovir toxicity. Then we will discuss how we'll grade the drug toxicities in different grade, like grade 1, 2, 3, 4. And then if the toxicities develop, how we will plan to substitute the drug in the same class. And if not possible to substitute the drug simultaneously after doing the plasma viral load, we can switch to the second line or third line antiretrovirals, not only for the toxicities, but also for the viral load, increased viral load. So, and lastly, we will discuss about the guidance in impaired renal function of antiretroviral drugs. Now, the management of antiretroviral toxicities. Okay. So, whenever we discuss the first line drug toxicities of first line class, class specific or drug specific, and it will helpful to identify the drug toxicity. It will be helpful for both the patient and the program and the antiretroviral center staffs. How? Now, if the patient develops toxicity and we can diagnose the toxicity at the first time when the toxicities are minimal, like nausea, vomiting, or headache, or any mild rash, so we can identify the toxicity. And if we cannot identify the toxicity in that level, then it may progress to the severe toxicity. Then probably the patient will not become adherent to the drug and will not retain in the program. So it will program it from the programmatic aspect. It will both the problem for the retention of the program in the retention of the patient in the program, and to identify the toxic drugs and their dosage. And also for the ERT staffs, it is very important to identify the toxicity at the very baseline, because then they will inform the program personnel about the drug toxicity and simultaneously check the patient's retention in the program. But before documenting that the identifying drug is a toxic drug for that particular patient, we have to rule out something. We have to rule out whether these complications, these probably some GI tract complications, nausea, vomiting, or jaundice, or flatulence, or constipation, or diarrhea, they are related to the complications of HIV or other infection. It is very important. They are related to jaundice of hepatitis A, B, C, E, or maybe due to drugs toxicities of antiretrovirals. So you have to identify the toxicities are due to antiretrovirals or due to associated HIV illness or manifestation of an opportunistic infection. Like most of the cases of tuberculosis patient, they usually present with fever, irregular fever, sometimes weight loss, cough, and sometimes they present with jaundice also. So you have to identify whether there is associated opportunistic infections or not. Sometimes comorbid condition, you have to identify whether diabetes mellitus or hypertension or chronic kidney disease are associated with no, with anti HIV or not, because sometimes uremic patients may develop signs and symptoms due to uremia, but not related, those are related to the toxicities of antiretrovirals. But you have to identify the whether the drugs are the culprit or the disease condition itself maybe are the symptom producing illness. So that's why it is very important to identify the drug toxicity, particularly antiretroviral toxicities for the adult and patients, what I will discuss in this case. So what are the drug classes we use? Usually there are the antiretroviral is a combination drug therapy where two NRTI and one INSTI or PI is the component as the first line antiretroviral drug. In nucleoside reverse transcriptase inhibitors, most commonly used drugs are lamivudine and zidovudine. Stavudine is already phased out in India, so we are not used stavudine nowadays. Among nucleotide reverse transcriptase inhibitor, that is NTRTI, commonest drug use is tenofovir disoproxil fumarate, which can cause nephrotoxicity and bone toxicity. So bone demineralization, that is osteoporosis, and in severe cases, it may cause osteomalacia. And what are the other drug? It belongs to the integrase transfer inhibitor class, where the second generation integrase INSTI we use in our national program is dolutegravir. Previously, raltegravir was in use, but it is not used nowadays. So we have to wait the common side effects and adverse effects of dolutegravir and other class drugs also. And in NRTI, which are not using nowadays, common drugs are efavirenz and nevirapine. Both can cause drug rash, and nevirapine is notorious for toxin hepatitis, and sometimes efavirenz also can produce hepatitis, and efavirenz is notorious to cause CNS side effect. So we have to know. And among the NSRTI, that is nucleosidase reverse transcriptase inhibitor, these drugs acts by mitochondrial injury. So the host cell mitochondria also affected. So most of the toxicities are due to mitochondrial injury. They are lactic acidosis in severe cases, rarely pancreatitis, lipodystrophy is common in long-term use, hepatic steatosis is also common in long-term use, peripheral neuropathy, it can develop with the stavudine use even after 6 to 7 months. Anemia is short-term toxicity of zidovudine. Sometimes it may be the long-term toxicity, but usually develop within few months of zidovudine use, and myopathy is common for all NRTI. Among the nucleotidase reverse transcriptase inhibitor, tenofovir disoproxil fumarate is common drug, which we are very much using in our program. It can produce renal toxicity. It can produce the proximal tubular damage of the glomerulus and renal tubule. So it can causes renal absorption of the elements which are absorbed from the proximal tubule. So it can cause renal toxicity, and simultaneously calcium phosphorus absorption is also hampered. So it causes bone demineralization. Zidovudine, I have already mentioned, it can cause anemia, neutropenia, and simultaneously bone marrow suppression. Some GI intolerance are which are very common with the NSRTI, that is nausea, vomiting, and sometimes flatulence. Headache is also common. Insomnia, myopathy, though rare, it can happen. Lactic acidosis and hyperpigmentation of nail and skin. Lactic acidosis is a long-term toxicity, but hyperpigmentation of skin and nail is common in case of zidovudine use. Lamivudine is very patient-friendly drug, has minimal toxicity in adult, only severe pancreatitis in children. And rash, I have published one paper with the lamivudine rash. If the rashes are very rare in case of lamivudine use, but when developed, it is very severe. So you have to keep in mind the lamivudine drug rash. And another one is abacavir. Abacavir is very nice drug and it is renal friendly drug, but it is not 3 to 5% cases. It produces the hypersensitivity reaction. It may be in form of fever or GI tract symptoms or respiratory tract symptoms. So for which you should be very careful to identify as early as possible the abacavir toxicity. And abacavir hypersensitivity is linked to the presence of HLA5701 gene, and it is tested before use of abacavir outside in the Western countries, but not in India. And another important thing of abacavir use, that when hypersensitivity reaction is noticed, abacavir must be discontinued and immediately and never rechallenged in future. Efavirenz and nevirapine, both drugs are phased out in our national program, but I have mentioned that nevirapine is notorious for its hepatitis, usually developed within 12 weeks of its use, and sometimes the life-threatening hepatotoxicity we can see, we used to see, and skin rash is very common. Sometimes it may produce SJS, that is Steven-Johnson syndrome, and it may extend up to toxic epidermal necrolysis. Usually develop the skin rash and hepatotoxicity develop within few weeks of nevirapine use. Efavirenz is also producing same side effects like nevirapine, though it is hepatitis is less frequent compared to nevirapine, but central nervous system toxicity, dizziness, somnolence, insomnia, confusion, hallucinations, agitation, daytime sleeping, vivid dreaming are common with efavirenz use. And for that CNS toxicity, many of our patients you discontinued the medicine. So it was and become a patient of ART failure. So it is very important to identify the drug toxicities at the initial level as early as possible. And among the PI, atazanavir, ritonavir, and lopinavir, ritonavir are mostly in program nowadays, along with darunavir, ritonavir. Atazanavir, ritonavir usually causes indirect hyperbilirubinemia. Only symptoms is the yellowish discoloration of sclera and without elevation of liver enzymes. So you have to convince your patient that it will not make any harm and the jaundice will not become very much severe. And so with counseling, after diagnosis of atazanavir toxicity or atazanavir side effect, that this drug may be continued. But sometimes this is associated with the chronic liver disease and sometimes it produces the severe hepatotoxicity, then you have to discontinue the medicine. Lopinavir, ritonavir usually causes diarrhea, nausea, vomiting, and abnormal lipid profile. Abnormality in the lipid profile are more frequent with lopinavir, ritonavir compared to atazanavir, ritonavir. And diarrhea is component when we use the ritonavir drugs. And you have to be very careful when you use with simvastatin, because simvastatin significantly increase the there is the significant increase in the blood level of simvastatin when we use with lopinavir, ritonavir, because ritonavir is an enzyme inhibitor and it may causes the increased blood level of simvastatin. Now dolutegravir, it's a very much in the program. Previously, another INSTI, the raltegravir was used in a program, but now it is not used. It is a reserve drug, and hepatotoxicity is common, though it is mentioned, it is not that much very common. And these INSTIs are in the program since 2020. So we have to identify the long-term toxicities of dolutegravir in long run, and NACO is doing some program multicentric study, and they will come out with the result. But the toxicities we have noticed are hepatotoxicity, weight gain in long-term use, few patients develop skin rash with dolutegravir use, insomnia, though it is mentioned in the book, but it is less common in routine use. Now the toxicities in term of duration of use of the drug. Sometimes there are short-term toxicity, some are medium-term toxicity and long-term toxicity. In case of NRTI, when we use zidovudin, the GI system toxic side effects along with headache and diarrhea and bone marrow suppression are short-term toxicities. Bone marrow suppression with anemia mostly and neutropenia may develop in long-term toxicity, medium and long-term toxicities also, and lactic acidosis and proximal myopathy can develop in long-term toxicity. Lamivudine, usually short-term toxicity is only skin rash and pancreatitis in case of children, and there is no long-term toxicity of lamivudine use. Stavudine is already phased out, and abacavir, short-term toxicity is hypersensitivity reaction. In case of INSTI, only short-term toxicities are identified till date. These are nausea, diarrhea, insomnia, sometimes CNS toxicity like psychosis and rashes, though they are very few in number, but they are identified and notified. And hepatotoxicity is another problem which will come in next few years, if especially associated with alcoholic liver disease. The studies are going on. And sometimes raltegravir was used previously. Similar type of toxicities like dolutegravir develop, but no long-term toxicity detected till date. And among NNRTI, efavirenz and nevirapine, which we used these drugs before 2020, CNS toxicity was common with short-term toxicity, as short-term toxicity with efavirenz along with hepatotoxicity, both for efavirenz and nevirapine, and they are notorious for causing skin rash. Now, sometimes there are overlapping toxicities. That means ART drugs causing toxicity, but same toxicity can develop with the simultaneous use of other group of drugs which are non-antiretroviral. Like bone marrow suppression can also be caused by cotrimoxazole use or dapsone use or pyrimethamine use. Cotrimoxazole can cause bone marrow suppression, pyrimethamine can cause megaloblastic anemia, ganciclovir can cause bone marrow suppression, amphotericin B can cause bone marrow suppression. So when we use simultaneously with other group of drug, it is very difficult to identify, but you have to identify the noxious agent which can cause the specific type of toxicity. Hepatotoxicity, similarly, anti-tubercular drug like INH, rifampicin, pyrazinamide can also produce hepatotoxicity along with antiretrovirals. And commonly used fluconazole we use for oral candidiasis, and cotrimoxazole as prophylaxis can also produce hepatotoxicity. So many drugs can produce hepatotoxicity. So you have to identify whether ART is responsible for that jaundice, that hepatotoxicity or not. Peripheral neuropathy, so many clinical condition along with HIV neuropathy and leprosy and alcoholic neuropathy, diabetic neuropathy, many drugs, INH can also produce neuropathy along with stavudine. So you have to identify the culprit drug and you have to search for the other condition to rule out the other level, other cause of particular scenario. Same pancreatitis, alcoholism can also cause pancreatitis. Sometimes cotrimoxazole may also be responsible and for pancreatitis. So before stamping the stavudine as pancreatitic agent, so you have to rule out the other drug or the scenario associated for doing the same similar complications. Now, dolutegravir. Dolutegravir has several beauties. It has a high genetic barrier of resistance, and it has an excellent tolerability, and it has limited drug-drug interaction. You can use in any stage of pregnancy nowadays. So it is used as a first-line drug, second-line drug, and also in the third-line drug in our national program. And most of the side effects are for short term, like GI intolerance, skin rash. Skin rashes were reported even from our center also, and it is usually developed within a few days of dolutegravir toxicity. Minor grading of skin rashes, grade 1 and 2, need to change the drug. If develop CV grade 4 toxicity, then you have to switch the drug. And usual raised concern with dolutegravir is that neural tube defect in fetus when it is used in pregnancy and weight gain. Long-term data will talk about the weight gain, and reporting on severe adverse effect of hyperglycemia or diabetes was limited across the study. So in a study done in the Brazil, it was shown that the potential risk of NTD associated with dolutegravir use at the time of conception is no longer statistically significant when comparing the prevalence of neural tube defect between the preconception of dolutegravir and post-conception non-dolutegravir ART regimen, and it is around 0.2%, less than 0.2%. So other adverse effect of pregnancy outcome: miscarriage, stillbirth, preterm birth, low birth weight, small for gestational age, and neonatal mortality were not increased with the maternal dolutegravir use compared with the efavirenz containing ART regimen when this regimen was started preconception or during pregnancy. So woman-centered right-based approach should be done. So the woman and the adolescent girl living with HIV to make informed choice about their health, including their sexual and reproductive health and choice of ART. But we will counsel her as in a way so that the dolutegravir should be taken by the woman even in the pregnancy. Few important point of dolutegravir: that women of childbearing age should be provided appropriate information about benefits and risk associated with the use of dolutegravir, and also the medical guidance that is appropriate to her situation and supported in making informed choice. If a woman plans to become pregnant, women should be counseled on the benefit of dolutegravir based regimen, and they should be explained about the slight risk of possible NTD in babies born to a small proportion of women who get pregnant while taking dolutegravir. Even after explaining the benefit and the risk of dolutegravir, if the women do not wish to take the dolutegravir based regimen, alternative option such as efavirenz based regimen may be considered. Women who are already on dolutegravir based regimen and become pregnant should continue this DTG based regimen and adequately counseled. All newly diagnosed pregnant women, irrespective of duration of pregnancy, shall be offered DTG based regimen as a preferred regimen, and all women who are pregnant not on dolutegravir based regimen should be shifted to dolutegravir based regimen as early as possible. Now, dolutegravir and weight gain. Weight gain is mostly seen in the ART backbone when dolutegravir is used with the TAF, that is tenofovir alafenamide based regimen. But we in the program, we use TDF instead of TAF. And it is seen that is weight gain is minimal with TDF compared to TAF based dolutegravir regimen. An effect on gender on weight gain appears to be ethnicity dependent, with higher rates among the African women compared to men. And whenever nowadays there is test and treat policy, and many of the patients are diagnosed in the very advanced stage of HIV illness with a very low body weight with and other opportunistic infections. So body weight is minimum, and when we start dolutegravir based regimen and there is a little weight gain, and the patient will get soon, will feel better thereafter. So probably low CD4 count and high HIV RNA were highly prognostic indicator for better weight gain. That may be a one reason for higher weight gain with the patient with low CD4 count and high viral load when dolutegravir based regimen was initiated. And more data will require to document long-term body weight, weight gain comments, and for dolutegravir based regimen either with the TAF or TDF based regimen. Now, renal insufficiency with dolutegravir. Dolutegravir can reduce the tubular secretion through inhibition of the OCT2 with a noticeable which is non-pathologic and non-progressive increase in the serum creatinine. So there is no risk of renal toxicity, and dolutegravir can use even with the CKD, even with the very low EGFR, even the patient with the dialysis. So patient with the renal insufficiency, no dose adjustment required for any INSTI, except the day on the day of dialysis, doses has to be taken post dialysis. Otherwise, the drug will washed away. Renal and hepatic insufficiency regarding dolutegravir, no dose adjustment layer of DTG is needed for hepatic insufficiency in case of child pug 1A and B, but dolutegravir should not use in child pug C. Now, points to be to consider while prescribing dolutegravir, that is adequate counseling of lifestyle and dietary changes should be needed, because HIV is a chronic disease nowadays. So the patients are not dying due to HIV, but there is non-communicable diseases, and dolutegravir causes weight gain. Dolutegravir has minimal implementation on lipid profile. So adequate lifestyle guidance and dietary changes should be required whenever any patient will start on antiretroviral drugs. And blood pressure measurement and blood sugar monitoring, adequate counseling of pregnancy, adequate monitoring of lipid profile, all that are required with all ART regimen, not only for the dolutegravir. Now, another drug toxicity is tenofovir. Tenofovir is very much component of first line regimen. Sometimes it may be a second line drug when the zidovudine is used as the first line regimen. So you have to know and the tenofovir toxicity. And in our program, we are not using TAF, we are using TDF. So TDF is a very good drug, and only it has a very good overall safety profile and few metabolic side effects, except renal toxicity, which can occur in 3 to 5% cases and decrease bone mineral density. How it causes renal toxicity? Now, it can produce different type of renal toxicity. It can produce only proteinuria and glycosuria before development of any visible renal changes with the blood test, like increase in the blood creatinine level. We can diagnose early tenofovir toxicity by measuring the urine test, tape test, urine test for proteinuria and glycosuria, and even in spite of the normal creatinine level. The pattern of the kidney injury may be acute kidney injury with acute tubular necrosis. Sometimes there is proximal tubular dysfunction because the renal TDF causes the dysfunction of proximal tube. So the most 80% of the renal absorption happen in the proximal tube. So there is hypophosphatemia, hypokalemia, hypouricemia, and there is increased protein loss, proteinuria, and amino aciduria, and hyperuric aciduria, so and glycosuria. So it is very important to document proteinuria and glycosuria in spite of normal blood glucose level, that is normoglycemia, and glycosuria and proteinuria as very significant to identify the early tenofovir toxicity before documentation of raised creatinine value. So it is very important to diagnose the early renal dysfunction. And in long-term use, it can also produce CKD. And it is very difficult to use tenofovir in CKD patient. And the risk factors for development of the kidney injury with tenofovir, it is that already elevated level of the serum creatinine, that is already damaged kidney, and older age group associated with diabetes mellitus, hypertensive kidney disease, advanced HIV infection, where there is even low body weight, associated hepatitis C injury, concomitant use of boosted PI, concomitant use of other nephrotoxic drug. So there is chance of development of more nephrotoxicity with tenofovir. So given the potential for nephrotoxicity, so avoid administration of TDF to those with the GFR of less than 60 or elevated serum creatinine. So a program has option to opt out to abacavir based regimen. If you think that is the renal function is compromised and GFR is less than 60, better to start with abacavir based regimen. And or if the patient is on tenofovir, switch to abacavir based regimen, because it is renal friendly. And renal function and proteinuria should be monitored whenever you use tenofovir, every 3 monthly for first year, then every 6 monthly, and monitor urine for protein and sugar, I have already mentioned. And more frequent monitoring may be appropriate for patients with additional kidney risk factors. Now, and a few other points, that is, if in tenofovir treated patients who experience GFR decline by more than 25% from baseline and to a level less than 60 milliliter per minute, it is recommended to substitute alternative ART to TDF for TDF, and particularly those with evidence of tubular dysfunction. I have already mentioned that abacavir is a best choice in spite of tenofovir. Lamivudine dose adjustment needed according to the creatinine clearance of creatinine of the patient. If GFR is more than 30, so full dose of lamivudine can be used. If GFR is less than 5, then 1/4 dose of lamivudine should be used, and in between 15 and 30, half dose of lamivudine should be used. Now, the spectrum of bone toxicity due to tenofovir, it can causes bone demineralization because there is hypophosphatemia and there is impaired calcium absorption through GI tract. So there is hypocalcemia. So there is more bone demineralization, and also osteoclastic activity is increased. So osteoporosis and osteomalacia are more important whenever suspecting tenofovir bone toxicity. And in severe cases, it can produce Fanconi syndrome, lead to hypophosphatemia, and I have already mentioned causes osteomalacia. Even the patient may present with the bone pain. These are the references. Now, proactive approach to manage ART drug toxicities. The clinical signs and symptoms of management of adverse effect of antiretroviral drug. So, in case of acute hepatitis, possible offending agents are NNRTI, nevirapine, efavirenz, and less commonly zidovudine, stavudine. So, clinical signs and symptoms of acute hepatitis are what? Jaundice, enlargement of liver, tender hepatomegaly, nausea, vomiting, anorexia are there. So nevirapine-induced hepatitis may have hypersensitivity component, and it can produce race also. So you have to identify. And then if you can continue the antiretroviral till the enzymes level is elevated more than 5 times of the upper limit of the normal. Thereafter, you have to stop all the ARV till it comes down to normal baseline level. And then substitute the most likely offending ART drug. In case of pancreatitis, We know that stabudine and rarely lamivudine can cause pancreatitis. So you have to identify a patient that develop pancreatitis. There is abdominal, most prominently nausea, vomiting, and abdominal pain. Mostly the back pain, and sometimes the pain in the left hypochondriac region, and then if you think of pancreatitis, you should stop antiretroviral and think of an alternative drug. In case of lactic acidosis, all the NRTI can cause lactic acidosis, particularly stabudine, which has already phased out. So symptoms of lactic acid is very critical. You have to identify. If you have not a mind to identify the symptoms of lactic acidosis, you may miss. Sometimes the patient may present with uremic-like symptoms, nausea, vomiting. Sometimes there is, due to acidosis, there may be fatiguity along with vomiting. Sometimes there may be cramp and abdominal pain. So hepatomegaly, anorexia, sudden unexplained weight loss. Sometimes may patient present with respiratory distress, tachypnea, dyspnea, and neurological sometimes. Sometimes may produce seizure also. So you have to identify the lactic acidosis is developed or not by measuring the serum lactate with a particular manner. How the serum lactate is measured, with the blood should be taken without a tourniquet, and the samples should be taken in the fluoroxylate vial, and the test should be done within half an hour of the drawing of blood. So it is very important, and you can do simply an ABG you can do and identify the serum lactate level. So if there is lactic acidosis, you have to discontinue the ART drug and use the alternative. Hypersensitivity reaction, notorious for abacavir and nevirapine. Nowadays, we are seeing less hypersensitivity reactions, especially skin rash with nevirapine. We are not seeing skin rash with nevirapine, but now it is a few skin rashes with lamivudine and dolutegravir we are noticing. Abacavir can produce hypersensitivity reaction, which can produce, we usually develop, the symptoms develop just after the drug intake. That is fever. Fever, maybe there is a relation of fever with the intake of drug, that the patient develop fever after 1 hour of drug intake and disappear after 3 hours. Again, after evening dose of the abacavir, then fever reappear. So there is a temporal relationship of the fever and abacavir. Sometimes the patient develops symptoms of GI tract with the drug intake. Sometimes the patient may develop the symptoms of respiratory tract, like the dyspnea, tachypnea. So you have to keep in mind that these drugs can produce hypersensitivity reaction. And if you confirm that these symptoms are due to abacavir, you should not re-challenge the abacavir. Now, the clinical symptoms. Clinical signs and symptoms and management of adverse effect of antiretroviral drugs. And now the rash. I have already mentioned that nevirapine was not, both the NNRTI, nevirapine and efavirenz were notorious for causing drug rash. Nowadays, though rare, dolutegravir can also produce drug rash, and lamivudine. The rash, we have to grade the rash. Rash usually occur within the first 2 to 4 weeks of treatment. Usually there is only erythematous maculopapular rash, usually confined like the rash of any viral illness. But sometimes in the grade 3 rash develop, there may be symptoms of generalized symptoms, that is fever, body ache, and systemic symptoms may be there, running nose, pharyngitis may be there. Sometimes grade 4 rash with mucosal involvement may be there, or mucosal membrane of oral cavity or eye or genitalia may develop. That then we will stamp this as a grade 4 rash. Sometimes it may extend up to Stevens-Johnson syndrome, or when it involves more than 30% of the body surface area, we will call it as toxic epidermal necrolysis. So how we will manage? Immediately stop all offending agents and give, in mild cases, you can continue the antiretrovirals with antihistaminic for grade up to grade 2 dash, but whenever systemic symptoms develop or mucosal is a membrane involvement there, you should immediately stop all the antiretrovirals with the conservative management till the patients become normal and all rashes disappear. And think of other drug if there is grade 3 or 4 hypersensitive skin rash. Now, peripheral neuropathy. The Stavudine was most important drug for peripheral neuropathy. If you think peripheral neuropathy and the Stavudine is the culprit agent, you have to stop the Stavudine and consider other NRTI. In case of diarrhea, usually lopinavir, ritonavir causes diarrhea. Usually it will control within 1 to 2 weeks. And if the diarrhea is not controlled beyond 4 weeks, then think of other drug, switch to ATVR, which comparatively cause less diarrhea comparable to lopinavir, ritonavir. In case of lipidemia and insulin resistance and hyperglycemia, if developed for use of PI and efavirenz, then you can consider replacement of the suspected PI by drugs with lesser risks of metabolic toxicity. Now, in case of gastrointestinal side effects, all antiretroviral causes minimal side effects, gastritis, nausea, flatulence, indigestion. They are usually self-limited. No need to discontinue the antiretrovirals, offer only symptomatic management. But for hematological malignancy, usually zidovudine causes significant anemia, and in case of severe anemia, the patient may present with the heart failure also, with severe respiratory distress. So if there is significant anemia, hemoglobin comes down to less than 9 gram%, then and neutrophil less than 500 cells per microliter, substitute NRTI with other drugs. For lipodystrophy, usually NRTI, particularly stavudine, and long-term use of the zidovudine can also produce lipodystrophy. So lipodystrophy syndrome, that is dyslipidemia, there is simultaneously lipoatrophy in the subcutaneous tissues and lipodystrophy, that is lipid hypertrophy in neck, that may cause buffalo hump and abdomen and breast. And so there is typical, say, look of the individual with the loss of fat in the face and the limbs and the buttock, and there is swelling of breast and abdomen, and there is buffalo hump. If there is significant lipodystrophy, so you have to replace the switch the antiretroviral, suspected antiretroviral with tenofovir or abacavir. In case of neuropsychiatric changes, efavirenz, I have already mentioned. So severe neuropsychiatric changes, efavirenz you have to change. We are not using efavirenz nowadays. Renal tubular toxicity, I have mentioned. If there is less than 60 GFR, you should better use abacavir in place of TDF. And in case of rash, drug eruption, including SJs or 10, if suspect NNRTI and there is grade 1 and up to grade 2, you can continue drugs under coverage of antihistaminics. But if it is beyond 2, that is grade 3 or 4 rash, should discontinue the drug till the patient, all antiretrovirals, till the patients become normal, and use another antiretroviral and not re-challenge the drug. Nowadays, more common drugs responsible for skin rash are zidovudine, rarely LPVR or ATVR, sometimes darunavir, ritonavir, raltegravir, dolutegravir can also and lamivudine can also produce rash. It is essential to identifying the offending drug before appropriate action is initiated. So there is an algorithm for simple understanding of the antiretroviral toxicities and along with the cotrimoxazole prophylaxis. So if there is severe rash, then you have to stop all the medicines, all antiretroviral and cotrimazole. Once the patient stop amoxazole and start only antiretrovirals with TDF, 3TC and dolutegravir. Nowadays, we are not efavirenz. So if it is well tolerated, you can identify that cotrimazole the offending agent. But if the rash appear with TDF, 3TC, TG, so these three drugs cause rash, then if you think that TTG is the suspected agent, you should continue TDF plus 3TC for 7 to 14 days. If the patient tolerates TDF plus 3TC, then you can identify that the dolutegravir can be a cause of drug rash. But if the patient develop rash with 3DF and 3TC within 14 days, then you can identify that either TDF or 3TC may be the responsible drug. Then if the rash reappear, then you have, whenever rash develop, you have to stop the drug and wait till the patient become normal. Then you can singly challenge TDF or 3TC. If the rash develop, you can identify the single agent. So you can build up your regimen according to the identification of new drug. If there is 3TC is the offending agent, you can make the regimen with TDF plus abacavir or AZT with dolutegravir. Or if the dolutegravir is a offending agent, you can start with ATVR in place of dolutegravir. Now we have to make the grading of the drug toxicity. I have already mentioned 4 grades: mild, moderate, severe, and very severe. And there is a grade 5, that is death. So
Ma'am, we have lost audio. Requesting participants to kindly bear with us. Ma'am will join again.
Ma'am, आप mute पे हो?
Ma'am, you're on mute.
okay, got it.
Yes, ma'am, you can continue.
So in case of mild toxicity and moderate toxicity, you have not to change the ART. But in case of severe and very severe, potentially life-threatening toxicity, you have to change the antiretrovirals. Shweta, please change. Please move. So I have already discussed that these are the blood parameters from up to which we have to mention the grading of the toxicity, that is whether grade 1, 2, 3 or 4 according to the blood level of the hemoglobin, neutrophil, platelet, bilirubin, glucose. We have to identify the level of toxicities, and according to which we have to either observe or have to change the antiretroviral drug. Please move on, Shweta. And these are again the what I have to mention, that in case of creatinine level, if it is more than 6 milligram per deciliter, you have to if there is life threatening grade 4 toxicity, you have to stop the antiretroviral. And in case of AST and ALT, up to 5 times elevation of the enzyme levels, that is hepatic transaminase and aspartate, you have to observe and you have to continue the antiretrovirals. Beyond that, you have to stop the drugs. So similar thing happens for grade 4 toxicities of alkaline phosphatase, bilirubin, amylase, pancreatic lipase, and lactate. Please move on. Sweta, please move on. So these are the side effects I have already mentioned, that is gastrointestinal side effects, nausea, vomiting, diarrhea. So in case of grade 1 and 2, you have not to do anything, but in case of 3, you have to observe and also change. You have to treat with the IV fluid or the antiemetic. And in case of the grade 4 toxicity, hospitalize the patient and manage accordingly. Please move on. In case of respiratory distress and urine related problem, if there is dyspnea, there is grade 1 dyspnea, there is dyspnea on exertion only and dyspnea on normal activity, nothing should be done. And in case of grade 3, dyspnea at rest and dyspnea requiring oxygen therapy, you have to admit the patient and take care of that problem. In case of urine analysis, if there is grade 3 and 4 toxicity, in case of grade 4 toxicity, obviously you have to stop all antiretrovirals and hospitalize the patient and manage accordingly. Gross hematuria, you have to again hospitalize the patient and manage accordingly. Please, Sheta, move on. So there are some side effects like fever. It may be grade 1 toxicity, and in case all grading of drug toxicity, fever may or may not be present. Headache, allergic reaction, drug rash, hypersensitivity reaction, fatigue, this can present in all level of toxicities with a different variety of severity. Please move on. So what is drug substitution? Whenever, please second, yes. So drug substitution means changing of the antiretroviral drug within the same class. So it is either due to adverse effect or drug-drug interaction or programmatic policy. It is not due to antiretroviral failure. There we have to switch the whole regimen. So what is a treatment failure? We have to switch the entire regimen to either 2 new drugs and one new drug from different class will add in that regimen. But in case of substitution, same class of drug can be used to make the new regimen. Please move on. So in case its general principle is that single drug substitution is for toxicity should be made within the same antiretroviral class. And in the if case there is severe or life-threatening toxicity, all ART should be stopped until the toxicity has resolved and revised regimen commenced when the patient has recovered. Whenever drug toxicity is suspected, rule out the other opportunistic infections or the other conditions that may be responsible for that, and grading of toxicity should be done and accordingly manage the patient. And for patients with the dual drug toxicity with the nevirapine or efavirenz, need substitution with PI, and this PI based regimen must be started by COE or ART Plus Center after review and approval from SASE. Please, next slide. I have mentioned that if there is zidovudine toxicity, switch to tenofovir, abacavir toxicity, switch to tenofovir, tenofovir toxicity, switch to abacavir, and efavirenz toxicity, switch to substitute to dolutegravir. So all these are substitution, they are not switch. Please, Sheta. So in case of efavirenz and nevirapine, already the program has changed. All of the patients of nevirapine or efavirenz subsequently substituted to dolutegravir based regimen. And dolutegravir based regimen, if the drug toxicity develop, they can be substituted to efavirenz regimen, or if the patient is on atazanavir ritonavir based regimen, and if there is intolerance, they should be substituted to dolutegravir based regimen. Similarly for lopinavir ritonavir, and if there is multiple exposure to NRTI, then substitute to dolutegravir based regimen along with the appropriate PI based regimen. Please move on. And in case of dolutegravir use and hepatitis B and C infection, if there is hepatotoxicity, you have to notice there's the 2 active drug against hepatitis B should be there. That should be tenofovir and lamivudine. If in any case you cannot use the one, then entecavir should be there. If in case of insomnia and the patient is older than 60 years, consider morning dose and substitute efavirenz boosted PI or dolutegravir. If there is weight gain, specifically if the person is older than 60 years, low CD4 count, female, and tenofovir alafenamide use, then monitor the body weight and promote anti-obesity measures, that is lifestyle modification. If significant increase despite measures, consider substituting efavirenz or boosted PI. Please change. So drug substitution guidance for impaired renal function, I have already mentioned dolutegravir, abacavir needed any dose adjustment. In case of renal failure, lamivudine requires dose adjustment when there is less than 30 GFR. So in case of PLHIV with more than 30 milliliter per minute GFR, then full dose of abacavir lamivudine can be used, and whether when there is less than 30, then lamivudine dose adjustment required with the full dose of abacavir. Please move. So these are the all I have to inform you. I have to giving you the messages regarding the drug toxicity, antiretroviral drug toxicities, and how you will manage these drug toxicities. So thank you.
Thank you so much, ma'am, for facilitating this session. Any questions from the participants? You can either unmute your mic or you can put your questions in the chat box. Any questions? Please unmute. Ma'am, I don't think there are any questions.
Okay.
Thank you so much, ma'am, for facilitating this session.
Thank you.
Thank you to all the participants for patient listening. We'll conclude the session now.
Thank you, ma'am.